Well, good evening, everybody that's kind enough to come and watch tonight. This is my third Facebook Live, and I said I'd talk about a topic to do with follow-up of heart valves. Now, if the communication is good, then I hope you'll be able to see this clearly. And if someone could post me a message if there's any problem with it being seen clearly, then I'll be most grateful. The main point here is about the protection of your heart throughout your lifetime, and this is the model which I've got here, which is showing the valves as you look up inside. And the most important one I want to talk about is this one here, which is the aortic valve, which feeds into the red pipe, controls blood going around the body, and the other one, which is inside the ventricle here, which lets the blood come in from the back of the heart with oxygen from the left atrium into the ventricle. Now, we talked about the fact that these valves can get diseased, and the disease can actually cause a problem with the valve function. So it may be damaged and become narrow, or it may be damaged and not sealed tight when it shuts, and this can cause a leak which can overload the heart, or increase pressure which can overload it. So there's two sorts of effects. There's a volume on the heart, too much blood going forwards and backwards, so it expands in size, and there's a pressure overload, which is the other sort of stress, which tends to not involve a bigger volume initially, but the higher pressure stimulates the heart to thicken up, rather like blood pressure does. So if you think of the fact that you have this heart beating once a second, up to 100 years we mentioned, and if you're starting to take more out of it than you're putting in other words, your bank balance is starting to go negative, every time you have a heartbeat, it's having to work harder. Now, over a period of time, you can keep paying the minimum payment and you can hold your balance steady. But at some point, that bank balance is going to be too big for you to correct, and you'll start having to take out a loan, and you may, in fact, go bankrupt. And of course, we're talking about becoming sick, ill, or even dying from the heart disease. So when you're coming along to the doctor for a appointment for your valve, what would you expect? Well, heart valves were initially diagnosed as abnormal by listening with the stethoscope and hearing a murmur. And children historically used to be followed up for many years, listening to see if a murmur stayed, got worse, or went, because we didn't have the technology to take a picture with an echo scan to see what was actually going on. So it relied on the skill of the cardiologist to listen, and to be honest, a lot of times they were wrong. But if it was quite severe disease, or there's a good history like rheumatic fever, then they might be able to make a correct diagnosis, and the signs have become so apparent with people with signs of heart failure, breathlessness and leg swelling, that it would be a clear sign that they needed operating on. But we're much more sophisticated now, and the bank balance that I mentioned needs to be addressed much earlier on, because if we're going to correct it and not be left with a deficit that can't be corrected or repaid, we're going to have some problems. Now, I'm going to put some pictures on the website later, but I just want to show you some ideas. And this is an example of the effect over time with disease of the aortic valve. And you can see it's a very flat line, and that flat line suddenly dives down at the end. All right, so just take it from me. It's not easy to see exactly, but there's various pointers on that. And those pointers are saying if you develop some symptoms, that line becomes steeper. So with this valve, the aortic valve getting narrow, what your doctor's doing is doing two things when you come to clinic. He's listening to your story. Have you got symptoms? He's looking at the tests that may have been done during or before the clinic, which is the ECG and the echocardiogram, and working out whether there's a change that puts you at risk of something that's irreversible. So an aortic valve might over many years remain fairly static, but it's an exponential change, and as it gets stiffer, suddenly it gets very stiff. And this can cause you to become breathless or to develop angina. And this is a warning sign. Now, the measurements you take, or the valve gradient, which might be 0 to 10 in a normal person, and then as it gets stiffer, the valve, there's a noise or turbulence, we hear a murmur, the gradient or the pressure behind the valve will go up. And the numbers we talk about is 30, 40, 50, 60, 70, 80, 90 to 100. It gives a clue. Now you can calculate from these and other bits of measurements the area of the valve, but people often go on the number, and if it's above 50, and certainly if it's getting towards 80 to 90, this is significant narrowing of this aortic valve. So when you come to the clinic, your doctor will have this information and he'll be measuring it over a period of time. So the reason for the follow-up clinic is not only just to see how you're feeling, but to assess you with the test and to advise you if you're coming to a point where you might need some sort of intervention to prevent it getting worse. Now that's the aortic valve. Now the mitral valve, which is the one I showed you that lets the blood come into the heart through the left atrium with oxygen, that's going into a low pressure chamber. And when the ventricle, which pumps at high pressure, squeezes the blood out, if it leaks, it's pushing a high pressure back into that chamber, and that chamber can get bigger to accommodate the extra blood. And every time that chamber empties forwards, there's more blood to take to the heart to pump out. So this is where you're getting your debits going out from your bank account, and you're losing maybe 10, 15, 20 or 30% of what you're pushing forwards out backwards. And that's starting to put a real strain on the heart. So over time, this heart will start to suffer. And instead of squeezing efficiently, and we talk about the percentage it contracts, normally 50 to 60% is a normal contraction. If the heart is under strain, it may start to reduce the amount it ejects with each beat. Now there is a bit of a paradox here. In the aortic valve, which is the main one pumping out round the body, because it's a high pressure chamber and the valve's under high pressure, I said it thickens up. So it tends to be very good at adapting for this pressure change. And the thickening up can be shown on the echo, but you can also pick it up on the ECG. So the doctor will be looking at your ECG and seeing the size of the electrical voltages, measuring it in millimeters, and seeing if there's a sign of change there. Looking at the mitral valve, however, this is different. This valve is now letting volume accumulate with less pressure, and the heart initially starts to offload with each beat backwards into the low pressure chamber of the left atrium. And paradoxically, when you assess that, you expect the percentage of blood ejected with each beat to go up, because it's trying to remove more, and some's going forward and percentage is going backwards. So the squeezing from the maximum size of the heart to the minimum size of the heart is a bigger percentage change. And if someone's got mitral regurgitation and their contraction starts normal and then goes up, and then you see it going back to normal, that is a sign that the heart is tiring. So when you're coming to your doctor to assess your mitral valve for a leaky valve, there'll be a different set of criteria that we'll be applying. What you need to do is ask your doctor when you see him, not just, are you worried about my heart now, but can you give me some idea if there's any change over time, and can you predict if I'm likely to need something to be done? And the things that can be done are initially controlling some of the environmental factors. If you have high blood pressure, then that can be reduced. That can help the heart cope with the extra workload. If you're anemic, that can be corrected. And those sort of metabolic upsets like an overactive thyroid, they can be corrected, but you're still left with a structural abnormality of the heart valve. And at some point, that valve might need either opening up or widening if it's narrow, such as the aortic valve, or in mitral stenosis, which is rheumatic scarred mitral valve, that can get narrow, that needs opening up. Or you may need it replaced if it leaks badly, and it's hard to fix a valve that's leaking badly, although you can repair a mitral valve. The aortic valve virtually has to be replaced by one means or the other to correct that. And as a consequence of this disease process, you will develop the symptoms of heart failure. And what I mentioned last time in my talk was heart failure. And I'll just pull up another little page if I can, which will be on the site. And it's showing some dips in a line, and it's showing the effect of changes over time with different insults. And heart failure can be insipid, and you don't notice symptoms until later on, and often that's too late. So I'll post that up to show you. So going back to where we are in the clinic, you may come away with a message that we'll see you in a year, or we'll see you in 6 months, or we will see you in 3 months, or we'll bring you in for a test. And this should be explained, the reason for this should be explained because of the concern, if you're shortening the interval, that there may be changes that are exponential or changes that are going much quicker than one could expect. So as far as the outpatient visit is, you'll get a letter to your doctor, and that letter to your doctor should explain to some degree what's going on with your heart and why you're being followed up at a certain point. The percentage changes, which people tend to concentrate on, are not the main issue, because you need to put it in context with how you feel. So if you're getting tired, or you're getting ankle swelling, or you're getting difficulty breathing, or you're getting problems with angina, then these are the things that you need to look out for. And from your own perspective, you shouldn't be waiting between clinics if something changes, because we can't always predict how quick these things are going to move in time. The problems that we have once we reach a stage of decision of operation is discussing with you the tests and the risks, and we have to weigh up in our own mind and try and explain to you as the patient what the benefits and risks are of doing surgery. So you'll have a group of patients that feel completely well, have a leaky mitral valve. We know over years the leak's going to stay the same or get worse, and the heart is going to get bigger, but the patient doesn't know that it's a problem because they feel fine. And this is the one whose heart is overactive, working extra, and then starts to decline. And what the message is now is that we say to the patient that you might feel fine now, but if we don't intervene in so many months' time, or whatever the anticipated decline might be from the test, you're not going to get a recovery. An operation's not going to put you back to where you were or prevent it getting worse. So there's going to be a group of patients that have to take on board a real risk of surgery or an intervention when they don't feel there's anything at the moment wrong. Then there's an easier group, of course, which are breathless or having angina, and that group will be clearly wanting something done. And in the particular case of the aortic valve, this is a very good sign to make a move fairly soon to come in and have some tests and set you up for some form of operation. For the aortic valve, we talked about replacing it mainly. In the past, people used to put a balloon like in an angioplasty on a vessel, but balloon and stretch the valve open, but it tends to close again and it tends to leak. So it's normally used in emergencies or for a holding manoeuvre before doing something more definitive. And more recently, the options are to do standard open chest heart surgery and replace the valve in people up to 80 or 90, even if they've got good constitution and no other major problems with their breathing. Or in those that aren't suitable that a surgeon might turn down, then you can have a valve implanted up through the artery in the groin, or occasionally through a hole in the side of the chest if they can't get up the arteries, and that's a stent of a valve round a balloon, and that's called a transaortic valvuloplasty. It's done through the skin, or transaortic valve implant, or TAVI is the name you may have heard. So there's a method of replacing a valve within the structure of the valve, and it squashes the sides out and it expands the ring and it fits the new valve in that space. Now, in doing that, there are risks because the coronary arteries are nearby and the blood supply to the heart needs to be assessed, so you end up potentially having a risk of heart attack if that's not dealt with. So prior to this sort of test, whether it's a coronary, whether it's a valve replacement or an insertion of a stented valve, you have a coronary angiogram, and that is a picture of the arteries, and that's done by putting through a tube into the artery of the arm or the leg and passing it round to the heart. It's put in with local anaesthetic. Sometimes you need something to relax you or sedate you, and when that's been done, the tube is screened round to the appropriate place at the entrance to one of the arteries, and dye or contrast, which is opaque to X-ray, is squirted in, and the film or the digital recording now is made as a movie and played back, and we can see the blood flow through the arteries. And if something's narrow or blocked, then we know that's got to be dealt with at the time of any intervention for surgery. And as far as the mitral valve goes, you can repair some of them if they're suitable and there isn't too much damage to the supporting structures. And just briefly, if I just remind you, this is the one inside the heart, and there are little strings or little guy ropes you might be able to see attached to the tips of these little white strands, those are the papillary muscle attachments to help the valve open and shut, and the muscles actually help manipulate the tips of the valve. But if they get damaged, either by rheumatic fever, get scarred and get shrunken and short, you can't stretch the valve because they're holding everything in a mess together in a mesh which is scarred. Or if they break, as in the case of a snap of one of those from a heart attack damaging the muscle, then you can't very easily sew it together. You normally have to replace the valve. So the risks that we have to talk to you about are, first of all, the test to check your coronary arteries, and that's the angiogram, and that's quite low. It's about 1 in 1,000 risk of serious complications, heart attack, a stroke, or an arrhythmia, but you take that small risk to get the information. When it comes to doing an operation, such as an open heart operation, or doing a transcutaneous or TAVI implant of a valve, then the risks clearly go up because you're poking bits of tubes or opening the chest and fiddling around the heart and disturbing the anatomy. And you can affect the blood supply not just to the arteries to the heart but to the brain. So there's a risk of stroke and a risk of heart attack. So the surgeons are very aware of this, and they take obviously the greatest care they can, but there's always a small risk. And the quote varies on the individual, but it's about 1 in 100 in good centres for standard coronary revascularization or bypass grafting. When you go to valves, it's a little bit more, 1.5 to 2%. And if you have to do bypasses with it, it adds a little bit of time to the operation. But that risk is taken so that you have a normal or almost normal quality of life, and hopefully a virtually normal lifespan if you catch things early enough. So the critical thing is to stop your heart having too much of an overdraft, getting into debt, and not being able to pay it back. So you may be able to stop what's gone wrong, you might reverse it, but you should hopefully be able to prevent it getting worse. And with modern medicines as well, once you've got the mechanics sorted out, you can actually improve the function of that heart by the medicines also taking some of the pressure off. We did talk before about a baggy or very poor heart with a very low percentage contraction or ejection fraction, and we talked about below, I think, 30-35%, and special pacemakers. And some people, when they've had a heart valve replaced, will need a pacemaker because at the time you disturb the conduction tissue which travels down the heart muscle near the valves, or it's been diseased by scarring that's been part of the process of this valve getting chalky, and it extends into the muscle surrounding the valve, and that can cause it to produce a failure of conduction and heart block. And those patients may come out with initially just some temporary wires through the skin to an outside pacemaker, and then when everything's settled they take the wires out, what they wean you off, and you don't need a pacemaker. But some people, the pacing never comes back to normal in your own tissue, and you need a permanent pacemaker put in, and that's put under the skin. And we can talk about that maybe at another session. There are others that have this baggy heart which need a special pacemaker that synchronizes the left and right side together, because they're not squeezing in synchrony, because there's delaying conduction down one conduction tissue to the other side. So one starts and the other one's a bit behind, and that seems to disturb the middle section, the septum, so everything's sort of moving against its partner the wrong way. So a resynchronization of the chambers may be needed in some people that have had heart failure that hasn't responded to the normal medical surgical treatments. So let's just recap. There's a lot said there, but we've concentrated on the problems of detecting a heart valve problem, which initially may be just the murmur heard by your GP. You'll get referred to specialists pretty quickly nowadays with that, and apart from doing an ECG and having a look at you and listening to you and maybe picking up what they think is going on, they will do the echo or cardiac ultrasound, and that will give us a baseline. It'll tell us the structure of the heart, whether it's normal structure, normal valves. If you've got congenital abnormality, of course, that may be picked up, but we're sticking with normal looking hearts to start with. It'll then say whether the muscle's active in a normal way, whether it's damage from other things such as a heart attack, and then they'll be able to look at the valves and they'll be able to see what's going on with that valve. and whether it's leaking or narrow, and has it caused any detriment at that stage. And then they can make a decision and explain to you, well, you have a valve that's got some disease, it's not to worry about, it's minor, you can go away, maybe come back in 5 years and have a check, or if you get breathless or something happens, serious. And then you've got another group where you can say, well, it's starting to show some changes, we'd like to see you once a year. And this is where people come back and forth to the clinic, and I've often asked them, well, what did you think of your last appointment? What did they say? And to be honest, I know it's a year ago, but they can't really recall why they're coming, other than the doctor wants to see them. And I think it helps if you know why you're coming. And I think it helps if you're given a little checklist to say what to look out for. And you can use that as a reminder. Now, if somebody is then told you've got serious heart disease, that can be quite a shock and quite a nasty experience, because you might come alone to the clinic. And if that happens, it may be that next time you come, you should bring somebody along with you if you need support. There are books we can give out and literature, and you can look stuff up, and that can help you in explaining things. And in the clinic, I try and draw a picture or give some information out, but there's never enough time for everybody. So you may have to come back and have a second consultation, or go to your GP, and your GP can then try and go through the letter that you've been sent. It doesn't seem to work as well as it should do, and that's another reason why I'm giving these Facebook Live sessions. Now, I'm talking into the small screen of an iPhone rather than my laptop, because I didn't want to risk a problem with the internet. So I'm not seeing questions coming up on the bottom as I thought I might. But if you'd like to post questions, because I've seen a couple of blips of thumbs up or hearts coming up, so I know someone's watching. If you'd like to post some questions, maybe after I've put a couple of comments on, I'll try and answer them. And I hope that, like previously, a lot of people will get to see this when it's recorded a bit later, because they couldn't make tonight, and we'll be able to take back some information that's useful from this. Now, we've done about 22-23 minutes. I've done it on 2 valves. I'll just quickly mention a couple of other related things. The right side of the heart, the valve or the tricuspid valve on that side can be a problem. Tends not to be operated on, it's very rare it does, but if it leaks a lot, you can get a lot of swelling of the legs without breathlessness on the lungs initially, and you can get problems with the liver being distended because the pressure goes back onto the liver. So that's a less common valve to be a problem that's operated on. And then the other valve is the one going into the lungs, called the pulmonary valve. Again, that tends not to be a common one that troubles us. It's more like to be a problem if you're born with a narrow valve, or you've got one of the rare congenital conditions such as missing chamber divisions or holes in the heart, and the aorta and the pulmonary artery that aren't quite in the right place, so they're a bit narrow, and the valve itself can also be a bit narrow, so that the whole outlet, the whole structure is disorganized. And people may, in your vicinity, have been sent with a young child with a funny murmur and looks a bit blue, and they might turn out with a condition such as tetralophalangy, and that is a complex operation that has to be done. And then these patients grow up with the disease, and it changes as they get older, so they may need further operations, and they go to a different sort of clinic, and that's an adult congenital heart clinic. Now, I'm not an adult congenital heart doctor, but occasionally we get people coming through, and because they're complicated now and living into their 40s, 50s and 60s and having children, having families, they need special follow-up. So if you've got a child that's come through the system, or an adolescent, they may not go into the normal adult cardiology clinic. They'd be sidelined into a very specialised clinic because there's very special needs for them. I think at this stage there's probably enough information. I just hope that some of it sticks. If you'd like to go back and have a look at my earlier video on the anatomy of the heart, remember what I told you about measuring your pulse and blood pressure, because those are the things that you can influence that might affect a valve problem that's currently being picked up as at risk of causing a problem. You can lose weight, you can still exercise, but remember not to ignore symptoms between clinics. So if you develop new chest pain, you get a dizzy turn or feel faint, something out than ordinary, don't wait a year for the clinic. either go to your GP and say something's changed, can you refer me back sooner? Or if you've had an instruction from the clinic to say if this happens, you just get in touch directly because you're coming close to an operation, then you can normally ring up the hospital through to the department or secretary directly. So I wish you the best of the rest of the evening. I hope this has come across clear and the image is good, and I'll play it back afterwards, and if there's any problems I shall be uploading the video I've done simultaneously on my laptop because I don't know how to get it to stream and record together. Thank you for that. I think Malcolm's given me a couple of thumbs up, so I'm pleased with that. So I'll say good night. There will be another one in about a week, and suggestions are welcome. Otherwise I'll work out something that is continuous with this, that keeps the theme running. Good night all.